Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and a long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic originally and now pretty much anything else, infectious disease or infection prevention. This is the last week of November. Hopefully everyone had a peaceful and safe and fulfilling Thanksgiving holiday or weekend. Going around right now, as I'm sure everyone is quite aware, is the continued increase in respiratory virus season. So RSV definitely has made its presence known, along with continued rhino/enterovirus, some adenovirus, and as we'll talk about with one of the questions, influenza is absolutely making its slow start here in Arizona. For those of you tuning in from other parts of the country, especially those in the East Coast, imagine you are thoroughly into flu season with increasing cases of RSV already filling your hospital wards. In terms of SARS coronavirus 2 and COVID-19, the newest news, or I guess the newest subvariant of Omicron, is the BA.2.86. This is the newest multi-resistant, multi-mutated subvariant of Omicron variant. And in last reports, the number of new cases reported in the United States has tripled over the last 2 weeks, but still accounting for just 10% of new cases. Importantly, this subvariant, like all the other recent ones, has not shown any increase in severity or virulence or degree of disease, but just continue to be highly infectious and great potential to infect those who are not vaccine protected or those who are younger and have not yet been vaccinated. So definitely it's out there. In terms of disease associated with COVID-19, it continues to be primarily upper respiratory. In adults, most people are reporting just but a severe sore throat with the malaise, the fevers, flu-like symptoms, etc. In kids, that is also true, and we continue to see refractory croup-like illness specifically due to SARS coronavirus 2. So other than that, not a huge amount of new things to report in terms of what's out there for viruses. I suppose, though, we should note that viral gastroenteritis season absolutely is out there as well. Certainly reports of norovirus all over the country. For those parts of the country that experience rotavirus, you are absolutely seeing those as well. And an interesting current food-associated outbreak of salmonellosis associated with cantaloupe, primarily in the Midwestern states and focusing right now in Minnesota. So be careful with the cantaloupe, or if you have somebody with what appears to be a bacterial enteritis, ask the screening questions about fruits and other types of foods ingested. So with that, on to the questions, and thank you once again. We have several weeks worth since we took a break for the holidays. The first question is, with strep cases on the rise, do I think we will start to see case numbers return to pre-pandemic levels? And with antibiotics becoming more resistant, what do we recommend as the best choices of treatment? So that there are, of course, several streps that the questioner could be referring to. The first one would be group A strep, or strep pyogenes, the source of strep pharyngitis, invasive disease, cellulitis, scarlet fever, rheumatic fever. And certainly countrywide and also in Arizona, we have been seeing a continued increase in the number of cases of active group A strep disease, primarily streptococcal pharyngitis or strep throat, but also increases in scarlet fever, and also, unfortunately, an increase in cases of acute rheumatic fever, some presenting with carditis, so having mitral regurg, for example, with a new murmur, others presenting with Sydenham's chorea. So that is definitely out there, and those numbers are absolutely increasing. Many parts of the country are reporting already a return to pre-pandemic levels, and in some cases exceeding pre-pandemic levels in terms of invasive disease. In my practice region, we have had several cases of invasive group A strep toxic shock-like syndrome and group A strep severe sepsis with multi-organ involvement. So that is absolutely more prevalent than we've experienced previously. So be on the lookout for group A strep. In terms of antibiotic resistance, group A strep pyogenes, does not possess the machinery, the genetic code or the enzymes or anything else to become resistant to penicillin. So there has never yet, and is unlikely to ever be, reported a penicillin-resistant strain of group A beta-hemolytic streptococcus. That said, we all know that there are treatment failures in patients treated for a routine strep throat with our favorite amoxicillin, the pink stuff. And so how in the world could that be? It's not due to resistance from the organism itself, but several hypotheses circulate around that phenomenon. The first, of course, is inability to complete the full drug course or tolerate the antibiotic, and of course, that would make sense. But even in patients who are very adherent to their antibiotic course and complete their course, we're still seeing persistent organism detected on culture. And there the thought is that there are other organisms in the respiratory tree, the oropharynx, retropharynx, etc., that themselves are beta-lactamase producers, that produce the enzyme which would inactivate amoxicillin. So in those cases, one can escalate, if needs be, to a cephalosporin. And whether you choose a first generation like cephalexin or an oral third generation like ceftonir, both of those would be highly active against group A strep without experiencing the other organism-based resistance. Certainly, clindamycin would be a reasonable thought, although, of course, we have to keep in mind some of the palatability of clindamycin. It's not the best tasting antibiotic in the world. For those whose go-to is azithromycin, and that's not completely unreasonable, but I do need to point out that there is roughly 20 to 30% resistance of group A strep to the macrolides, such as azithromycin, reported countrywide. And certainly in my practice area, that is very true as well. So unlike the usual, let's do azithromycin if the patient is unable to tolerate a penicillin, I would just note some caution about that and perhaps choose instead a cephalosporin, or if the patient is beta-lactam allergic, to consider clindamycin instead. So that would be for group A strep. The other strep, though, that we need to be aware of would be Streptococcus pneumoniae, pneumococcus. And certainly as we continue to broaden our respiratory viruses out there, influenza specifically and several others as well, has a fairly high rate of secondary bacterial infection with pneumococcus. Influenza specifically, the hemagglutinin and the neuraminidase in binding the virus to its target respiratory epithelium exposes sialic acid residues, which are a preferred binding spot for, guess what, pneumococcus. So there's a specific correlation and association between preceding influenza infection followed by pneumococcal disease, whether it's pneumonia with effusion or empyema, acute otitis media, sinusitis, mastoiditis, and in some cases even sepsis and meningitis. So in that regard, so far, the pneumococcus which is out there remains primarily penicillin susceptible. However, as many have either discovered or heard from your vaccine reps or monitoring the literature, there has been emerging 3 new clinically predominant strains of pneumococcus that were not initially covered in the 13-valent conjugate pneumococcal vaccine, the Prevnar 13, but are covered in the new products, the 15-valent with Merck and the 20-valent with Prevnar. And of those 3 types, serogroup 3 is perhaps the most prominent in causing invasive disease. Very well covered by both of the new vaccine products out there, thank heavens, but, or I should say, and serogroup 3 has had an increasing report of some penicillin resistance. Cephalosporin susceptibility remains close to 100%. So in those patients in whom you suspect potential pneumococcal disease, whether it's acute otitis media or superimposed pneumonia, empyema, etc., a drug like ceftriaxone or cefuroxime, if that's your practice area, is going to remain clinically active and reliable, although currently the CDC recommendation, and based on antibiotic susceptibility epidemiology, ampicillin remains the preferred first choice for community-acquired pneumococcal pneumonia and other respiratory-associated infections. So that would be where we're at just in terms of antibiotic susceptibility. So great question. Thank you for bringing that up. Next question has to do with the CDC's new recommendations regarding hepatitis C testing in infants born to mothers who are hepatitis C positive. And can I review the changes? How are they different? So historically, and this is still true, hepatitis C in causing disease in babies with perinatal exposure, so exposed to mom who is hepatitis C positive herself, the risk of active hepatitis C infection is quite low, and estimates are from 3% to maybe around 12%. So an average of 10% of babies born exposed will actually develop a hepatitis C true infection. But of those babies, another 90% plus, and some estimates are lower, 60%, but most babies will resolve that infection spontaneously. No intervention, no need to do anything, no lasting risk of active hepatitis C or cirrhosis, or the feared consequence of hepatitis C infection being hepatocellular carcinoma. For those remaining few children or infants that do develop active hepatitis C that does not resolve spontaneously, those are infants that when they turn 3 years old will be able to be treated with the newest antiretrovirals, which are incredibly successful. They're oral regimens once a day, 8 to 12 weeks, depending on the drug product, with a high degree of cure in the adult population and even higher rate of cure in the pediatric population. So that is the current, and that has been the current standard, especially with the newer treatment regimens. The key, though, is that treatment is not available and not approved by the FDA until 3 years of life. So historically, there's been zero need to even test the babies until 18 months of life, at which point we used to check babies' hepatitis C antibody levels. Why not before 18 months? Because prior to that, there's still a chance that the maternal IgG to hepatitis C, which crosses the placenta, would still be present in baby's blood. But by 18 months, based on a wealth of evidence from the HIV perinatal transmission world, we are pretty confident that a positive hepatitis C antibody from baby at 18 months of life is valid and true, meaning the baby has true hepatitis C. So what changed? Well, what changed is that many of those babies in whom we were waiting until 18 months of life fell off the radar, did not come for presentation, did not come with that history, were not tested, and therefore were being missed with possible active hepatitis C that would have benefited from treatment once they turn 3 years of age. And in my practice region, many of those babies are babies born to mothers experiencing shelterlessness, polysubstance abuse, and babies typically are placed in foster care through a Department of Child and Family Services. And sometimes the message doesn't always get transmitted over to the foster family or the DCS caseworker that that baby needs testing. So the chances of capturing those babies and not losing the follow-up are higher, meaning we can retain the babies and retain them in testing, retain them in management if needs be, if we test earlier. And so now the recommendation is from 2 to 4 months of life, and most of us just aim for 3 months old, we can now send hepatitis C PCR testing, and you'll find, depending on your electronic ordering system or laboratory you work with, that it comes up as hepatitis C, either a quantitative RNA, a reverse transcriptase PCR, or potentially a qualitative, meaning yes or no. But either is fine. But basically, you want to test babies no sooner than 2 months of life, because there still may be some hepatitis C viral RNA particles transferring into baby's bloodstream. Not true infection, but enough to trigger a false positive PCR. But from 2 months on, and as soon as possible after that, around 3 months or so, test babies with hepatitis C PCR. A positive PCR then needs to be referred to your local friendly infectious disease specialist. Not that there's any magic in this, but just to establish a relationship so that your peds ID person can follow that baby every 6 months, following their transaminases, their liver function testing, their hepatitis C viral load, meaning how many RNA particles are in the bloodstream, and if the baby does not clear the infection spontaneously, then starting treatment at 3 years of life. So that is the why and the wherefore and the how. There is no magic to ordering a hepatitis C PCR. Absolutely anybody in general practice could and should feel comfortable doing so, but just keep in mind that it's certainly a patient who could be referred to Peds ID should you get a positive before that. Okay, great. Next question. My practice, like many others, has been experiencing low COVID-19 vaccination rates for the new booster. Do I have any recommendations on how to encourage parents to get their child vaccinated? Yeah, ongoing question. That this has obviously been something we've all been dealing with throughout the pandemic. And the reasons for the vaccine hesitancy are very much the same, meaning multiple possibilities. Some are challenging the science, some just don't feel the need, some are still waiting for more safety data to emerge in pediatrics. And I think many of us know that there are many who just acquired vaccine hesitancy in general. So all of those are, ultimately valid points of concern. Yes, we wish they would not be there, but parents or caretakers have acquired them. And so I believe our role as caretakers is to have the conversation. So there's no magic to it other than sitting down, taking the time, identifying the barriers to the vaccination, either for SARS coronavirus 2 or perhaps other vaccines as well, and then through a combination of sharing either personal stories, answering questions with evidence, science, whatever it can be, but ultimately that is still the very best way to proceed. Fortunately, there continue to be population studies which identify pediatricians and primary care providers as still trusted sources of information, even for those who are vaccine hesitant, whichever the vaccine is. So it's not like we're going into a loaded deck against us. There is still potential that our words of hopefully support and understanding and wisdom may yet still be heard and taken in, and we may affect a change in that decision against vaccines. The AAP, and certainly through several of its projects, has created, identified, and has available for download several podcasts and also videos, all talking about ways to address vaccine hesitancy. And in fact, several of those are available through the Arizona chapter of the AAP as well, based on several outreach QI research projects we've done with practices around the state. And in those, we sort of go over specific questions and teaching tools, and it's sort of motivational interviewing in a way to identify sources of hesitancy and address those specifically. But honestly, harnessing hopefully that trusting relationship which has already been developed with the family, with the patient going forward, has been found to be the most successful way to get past those resistances. Yeah, so there you go. Speaking of COVID-19 vaccinations and the new boosters, the next question is asking to clarify the COVID-19 Moderna doses for children ages 6 months through 11 years. So for that, I direct you to the CDC, and there's a downloadable PDF chart which goes through the updated COVID-19 vaccine formula, and it has everything which you would care to wish for. It's a very long address website, but I'll just read it off for you and basically search, vaccine schedule pediatrics, and likely the first hit that'll come up even on Google will be this chart. But it's cdc.gov/vaccines/COVID-19-COVID-19-immunization-schedule-ages-6 months-older.pdf. Sorry if that's fast, but again, I think the easiest thing to do is a search for this online through a Google search. But to answer the question specifically for Moderna vaccine, so not Pfizer yet, but Moderna vaccine, in the unvaccinated 6 months to 4 years of age patient, they will receive the 2-dose initial series. So first dose at 6 months or whenever they enter your practice, followed by dose number 2 at least 4 to 8 weeks after dose number 1. And that dose is 0.25 milliliters or 25 micrograms. And CDC identifies the Moderna vaccine vial as being it's a single-dose vial with a dark blue cap and a green label. And it's, of course, all these are intramuscular. For that same age group, 6 months through 4 years, who has received a previous dose of any Moderna vaccine, they get dose number 2 of the new booster, the currently available one, at least 4 to 8 weeks after the last one. Even if it's several months or even a half year or so, it's a single additional dose. And that will complete their primary series, not a need for a booster. For the patient who's already received 2 or more doses of a prior Moderna COVID-19 vaccine, which does not include the current new product, they get they get 1 dose of the new product at least 8 weeks after their last dose of whichever one it was. And these are all the same, 0.25 milliliters or 25 microgram dosing, single dose vials. That's 6 months through 4 years of age. For the 5-year through 11-year age, unvaccinated, they get a single dose of the new product at point of entry, so right now in your office. And that dose is, again, the same 0.25 milliliters or 25 micrograms, and it's the same single-dose vial with the dark blue cap and the green label. Sounds kind of fun. If that patient, 5 years through 11 years, has received any other prior COVID-19 vaccine doses, which do not include the current product, they get 1 dose of the current product, and then that considers or counts as the booster, and they are good to go. Anybody who's received any current dose of the current product, having received at least 1 prior dose of whichever one it was, is considered fully vaccinated, up-to-date, boosted, and they're good to go. So that's Moderna. For Pfizer, the 6 months through 4 years, unvaccinated, they get the 3-dose initial series, right? So remember, Moderna is a 2-dose initial series for unvaccinated patients. Pfizer is a 3-dose. So dose 1 at time of entry, dose 2 is at least 3 to 8 weeks after dose 1, dose 3 is at least 8 weeks after dose 2. So you can sort of spread, just to keep it easy, your 3 doses spread by 8 weeks. And that is the 0.3 milliliter or 3 microgram dose from a yellow capped vial with a yellow label. If that 6 months through 4 years has already received a previous dose of any Pfizer vaccine, then they get doses 2 and 3 spaced by 8 weeks as well. And if they received 2 doses, they get 1 more dose of the current product. If they received 3 prior doses, they got the primary Pfizer vaccine series with a former product, they deserve 1 dose of the current product, which will serve as a booster, and then they'll be fully immunized. And that goes for other products as well. For 5 years through 11 years, unvaccinated gets a single dose of the current Pfizer product, and then they are fully vaccinated. And again, or not again, but this is 0.3 milliliters, but it's the higher dose. It's 10 micrograms. So it's a blue capped vial with a blue label. So babies, 6 months to 4 years, yellow capped vial, yellow label. 5 years through 11 years, the older children, blue capped vial with a blue label. So if they're unvaccinated, they get a single dose of the current product, and then they're up to date. If they received any prior doses which did not include the current available product, they get 1 more dose as well that serves as a booster, and then they're up to date. So again, there's lots of ifs, ands, or buts. That's for otherwise healthy, not immunocompromised or high-risk children. There are other permutations of that, and without belaboring this in podcast territory, I encourage you to find, download, print out, whatever, that PDF. It's a very useful resource for you. Okay, next question. I read an article about the first pediatric flu death of the season here in Arizona. Do I feel like the flu vaccine this year is targeting the correct strain or strains? And what are the typical number of deaths in Arizona from the flu each season? So yes, as of, this podcast, we've had our first pediatric death occurring in a child in Yuma with complications of influenza. Typically, and even over the last year or so, this has been typical, there are 182 pediatric deaths in the United States. Last year, 6 occurred in Arizona. So it's a handful. Of course, each and every one is horribly terrible because it could be preventable. And the vaccine, even if it's not a perfect match, and even if it's not preventing influenza disease, the flu vaccine is preventing, with crossover serotype protection, preventing severe disease and those complications. So any pediatric death could and should be preventable by immunization, assuming the patient, of course, is a healthy, immune, intact individual. The vaccine match, meaning the predicted strains covered by each year's vaccine and how they match to what's actually circulating, typically are discovered after the flu season is over, which makes sense, right? Because as the flu isolates are being discovered and typed, that is emerging evidence throughout the flu season. However, CDC and local health departments are able to do initial points of match assessments, and in Arizona as well as nationally, the current vaccine products, the quadrivalent vaccine, so 2 type A's and 2 type B's, is protecting over 50% of the identified influenza A and B isolates out there so far, which is actually pretty good. Oh my gosh, only 50%. But keep in mind, this is preventing disease, all disease. Preventing severe disease, those rates are much higher. A typical year, the match is somewhere in the 40s. So the last couple years, the match was 42, 43%. So right now, the flu vaccine is a little bit better of a match than past years, but it's still too early to tell until after the flu season is over exactly how good it was. Regardless, it is absolutely still indicated to vaccinate every single child in the United States, worldwide of course, but in the United States, who is 6 months of age and older. And new this year through the ACIP and CDC is that egg or ovalbumin allergy is not a contraindication to vaccine. There are egg product and ovalbumin-free products out there which are easily as efficacious as the other routine products. So this year, quadrivalent vaccine for everybody, whether it's the injected, inactivated, or for those who are ages 2 years of age and older, the live attenuated intranasal vaccine, assuming they do not have underlying severe asthma, chronic lung disease, or other respiratory issues. But the key is this year it is still a quadrivalent vaccine. Next year, there is initial talk that it may go back down to a trivalent, dropping one of the influenza B vaccine strains, which has just not been found to be circulating worldwide, actually, but here in the States so far. So there you go. Thank you for that question. And we'll just see how this year goes. Hopefully we get a follow-up toward next spring once we're done with the flu season. And then last question. An article was recently released suggesting that COVID rebound is more common with Paxlovid than without. Do you think we will see a change of Paxlovid dosing in response to this? Yeah, interesting question. Yes, certainly there continues to be ongoing discovery regarding the risk and the rate of rebound COVID-19 in patients taking Paxlovid, and also whether that, certainly it is true, by the way, that the patients do have rebound disease, but is it truly an issue with how Paxlovid interacts with the viral replication, or is it potentially, and this has been proposed as well, that patients taking Paxlovid feel better much sooner, in fact, many times after 24 hours or so, and return to full school life, working out, etc., way too early, lower their immune system defenses, and suffer a recurrence of that way. Hard to say. It is hard to say. And certainly that informs the question, because changing the dosing of Paxlovid is not anticipated to make any risk of relapse any higher or lower. The current dose is formulated to be highly successful, highly effective at preventing or reducing, I should say, further viral replication. Just as a brief background, Paxlovid is a combination of two protease inhibitors. These are antivirals from the days of HIV management, and they basically inhibit creation of new viral capsules, new viral proteins within the infected host cell after the initial infection has occurred. So it's a very elegant way of preventing further replication of the virus. Some other antivirals, including remdesivir, which we use intravenously in hospital and occasionally as an outpatient IV. Remdesivir actually targets and decreases the binding of the virus to the ACE2 receptor on respiratory epithelium in the first place. But it is not a complete prevention. So the Paxlovid actually is a more effective and thorough way of preventing further viral replication. But, and here's the key but, initial viral infection with active virus still must occur before further replication can be prevented with the Paxlovid. So the patient on Paxlovid will still have active virus bound to their respiratory epithelium, and if they push it too hard and go drinking or whatever, or working out or whatever it happens to be too soon, they still have access to active virus, which could then reinfect, cause new disease, and the Paxlovid only works on virus previously bound and trying to replicate. So they would have to take a second course. So any further higher dosing is not going to change that. It's honestly behavior practices. So I think we've not heard the end yet of true associated risk of relapse, whether it's due to the Paxlovid's effect on protease inhibitor, protein synthesis inhibition, or whether it is something about epidemiologic practices. So stay tuned for more. But thank you for raising that question. It's still obviously an active issue. So, great questions, everybody. Thank you so much, and keep those coming. And as always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, hang in there. Many, many best wishes for a peaceful, safe holiday season, whatever your practices may be. Hang in there with the respiratory and the viral gastro seasons. Yeah, it's here, it's coming, it's going to get worse, sorry. But again, we've been there before, and these are all very familiar practices. So head down, keep it going, take care of yourselves, and know that you are greatly appreciated. Thanks for tuning in, folks.